Hello, my name is Kevin Kuppens, and in the next few minutes I will try to answer this brilliant question: what is and how to diagnose rotator cuff related shoulder pain. So let's start off with this suggestion by Chris Littlewood and colleagues. They defined rotator cuff related shoulder pain as symptoms of pain and signs of weakness related to the rotator cuff when it is loaded. And it is movement-related shoulder pain without significant stiffness. The suggestion by Littlewood and colleagues is closely related to the most recent definition of tendinopathy, but within these shoulder pain patients, it is rather impossible to blame one structure for all pain. So it is an overarching umbrella term, and lots of other more non-specific terms have been used currently, previously, and will probably be used in the future, such as subacromial pain and the much debated subacromial impingement syndrome. In clinic, we recognize this rotator cuff related shoulder pain as an activity-related and load-associated pain, typically located at the deltoid or the upper arm region. And during the clinical examination, we find a positive resisted testing that is often painful and weak in direction of abduction and external rotation. We should be aware of possible serious pathology when a patient comes in with severe shoulder pain. We should also be aware of a possible spine-related shoulder pain, and more regionally we should think and we should differentiate these types of shoulder pain from the stiff shoulder, the frozen shoulder, that typically shows a loss of range of motion, especially in the external rotation direction. And we should also differ these types of shoulder pain from the unstable shoulders. In the next few minutes, I will try to answer this question: on what measurements do you base the start of exercises in SAPS rehab? So SAPS refers to subacromial pain syndrome, and it is a term that refers to the more non-specific shoulder pain, in which we have used other terms such as rotator cuff related shoulder pain and also the much debated impingement syndrome. So as in every pain patient, we start with a thorough history in which the patient will most definitely indicate his or her specific situation, what activities, what movements do hurt most, and then we can proceed using some of the more generalized questionnaires such as the SPADI and the DASH, but also the questionnaires such as the patient-specific functional scale, in which the patient again indicates what is his or her typical functional problem that is dominant in the clinical presentation. We use symptom provocation tests to indicate the irritability of the situation. We might indicate some provocative mechanism, for example, by using more standardized tests such as the empty can test, but we can also use tests that are indicated by the patient during the history. For example, if the patient states that lifting the arm in a certain way is painful, well, then this way of lifting can become a symptom provocation test for this patient. So when we have this information about the provocation, about the irritability, we try to reduce the symptoms by using symptom reduction tests, such as the scapular assistance test. And these tests, they give us information about what way we can reduce the tests. So we can have some hypothesis about the driving mechanism, but again, this also gives information about the irritability. And of course, when we are able to reduce the symptoms within one session during this clinical examination, that's probably a strong element in your therapist-patient alliance. And last but not least, since these types of shoulder pain are characterized by weakness, it is important to test for strength. So we use handheld dynamometry, if possible, isokinetics, and certain muscle endurance protocols. During the next few minutes, I will try and answer this really interesting but rather difficult question: what limits range of motion more, pain or fear? And I will relate my answer to the active type of range of motion. So maybe we should reframe the question: what limits the active range of motion more, pain or fear? So let's start with the pain-motor interactions, and we know that pain might negatively influence motor skills, and we see this in patient situations. So when we compare the motor skills in patients compared to healthy controls, we see differences, for example, in joint position sense in the more active skills. And what's interesting is that when pain is experimentally induced in healthy participants, then we see a lesser amount of these negative interactions. So there is something different between the patient cohorts and the healthy cohorts that are induced with pain. So possible explanation is the more biopsychosocial context in which the pain patient lives, and there we see fear of pain, pain-related fear, fear of movement as typical, more or less the psychosocial constructs that are known to interfere with pain conditions, with conditions such as post-operative joint problems, such as the frozen shoulder. So this probably also might be interesting to find out in this population of more non-specific shoulder pain. What is known is that the patient expectations and the pain self-efficacy are of great value within the patient population. So those who have positive expectations and a good pain self-efficacy, they are characterized by a better prognosis. So important to be aware of that and to in any case stimulate these expectations and the self-efficacy during physiotherapy treatment.